Hi everybody, this is Rehaneh Akhavein. I'm cardiology fellow at Oregon Health and Science University in Portland, Oregon. Today I'm presenting a case of coronary manifestation of blunt chest trauma. Our patient, Miss CC, is a 66 years old lady who was a restrained passenger in a car that was rear-ended and pushed into a pole. Her GCS upon EMS arrival on the scene was 13. It normalized to 15 when the patient was transferred to the ER. She sustained the following fractures. She had a right first rib fracture, right pertrochanteric fracture with right thigh hematoma, left tibial fracture, and a couple of thoracic spinal fractures. Her vital signs upon transfer to the ER were as following. Her heart rate was 72 beats per minute in sinus. Her blood pressure was 163/71. Her saturation was in mid-90s on room air. However, as soon as she was transferred from the ER to trauma ICU, she developed acute onset retrosternal crushing severe chest pain that was pretty similar to her prior myocardial infarction chest pain that she had. And this is her EKG shortly after the chest pain was reported. As you see, there is some millimeter or so of ST depression in the lateral leads. The T waves are still upright. The patient is in sinus rhythm and there is no pathologic Q waves. Her peritoneal labs are as following. Her electrolytes were normal. Her creatinine and renal function was normal too. Her glucose was 407 and her hematology labs, including coagulopathy labs, were normal. Right after the chest pain was reported, the troponin was checked and it's a troponin I, and you see that it was 0.04. The upper limit of normal in our hospital lab is 0.08, so it's technically in detectable range but not elevated. At that time, cardiology team was not notified. However, about 6 hours later, the repeat troponin shows markedly increase in troponin, and at that point, the cardiology team was consulted. I just put the troponin I trend here and you see that it keeps rising pretty remarkably, and it peaked about 24 hours after her initial chest pain. To give you a background of her past medical history, she has history of coronary artery disease. She had DES to her distal RCA and DES to her ramus intermediate about 11 months earlier in another hospital. She also has mild to moderate mitral and tricuspid regurgitation. She has dyslipidemia, poorly controlled diabetes type 2 on insulin. Her hemoglobin A1C was 9.8% a few months earlier. She also has depression. Her past surgical history is non-contributory. She is a lifelong non-smoker and hasn't used any illicit drugs, and her family history is negative for premature coronary artery disease or any sudden cardiac death. Her prior to admission medications, she was on aspirin and clopidogrel, as she had gotten the DES about 11 months earlier. She is on beta blocker, high potency statin. She is on insulin and metformin and gabapentin for neuropathy. The initial echocardiogram early morning of the admission showed that the LV cavity size and thickness was normal. The LV ejection fraction was about 50 to 55%, and she had distal LAD akinesis, basal and mid-anterior hypokinesis, and the RV systolic function was normal. When the troponin started rising, although the patient did not have any chest pain, but due to the marked rise in the troponin, the decision was made to take the patient to the cath lab for an SME with rising troponin. Just trying to play this. So as you see, this is the RIO caudal of the patient, left coronary system. The axis was the right radial artery. And what we're seeing basically here is some lucency here in the ostial LAD, some LAD high-grade stenosis, and the circ system is diffusely diseased. We see the lucency better in other views. And you see the lucency is still there, and it was concerning, highly concerning for thrombus. And there is the mid-LAD high-grade stenosis, and also there is a ramus stenosis. This is the LAO caudal, and we see the ramus stenosis better. We actually, due to the overlap, we don't see the thrombus in the ostial LAD very well, but we have demonstrated in other views. Here you still see the lucency, you see the ramus that's diseased, and you also see the LAD that's stenotic, and also the left circumflex that's highly diffusely diseased. The RCA showed some non-obstructive disease in the proximal, in the PLV, and in PDA system. And you see that that's the previously placed stent that's widely patent actually. So at that point, a heart team approach was pursued. We talked to the orthopedic surgery team, and they stated that her hip fracture is in a way that if she doesn't get the hip surgery repair in a week, at most in a week, she won't be able to ever walk again, and she'll be a wheelchair-bound lady. She's only 66 years old, and she had been pretty active prior to that. So at that point, the decision was made to take her back for the PCI to the LAD. In order to decrease the clot burden, we started the patient on glycoprotein 2B3A inhibitor in addition to heparin infusion for 48 hours, and we decided to take the patient back to the lab for PCI 48 hours. Since her LVEDP was 31 millimeters of mercury at the time of the first coronary angiography, we decided, and also there was a thrombus in the distal left main and also ostial LAD, we decided to put the Impella and do the PCI under Impella support. The patient had Impella via the right femoral artery, and we started accessing the coronaries through the right radial artery. So I'm trying just to play the image. This is after the Impella was placed. You see that the thrombus is still there. There is still the lucency here. And the LAD stenosis and the ramus stenosis is very well demonstrated here. We're going just to go over the imaging quickly until we get to the result. The haziness is still here. And what I want actually to point out here is that both on the prior imaging and now, you see that there is an apical tapering and completely occlusion of the LAD, and it's because of the thrombus embolization that the patient had. And it was seen on the former, like the prior coronary angiography 48 hours earlier as well. And at this point, we decided to put a wire in the ramus, another wire in the LAD, and start ballooning up the LAD. And we knew that it's gonna cause more distal embolization, but we had to open that vessel. Now the balloon is going up in the ramus intermediate, and the stenosis was just proximal to the previously placed stent in ramus intermediate. The stent is going up here, and you see that we got a very good result. Then we went to do the intervention on the LAD. So this is a very good result, the stent placed in the ramus. Here the balloon is going up in the LAD. And here the stent is going in, as you see. And this is the shot after the stent was placed and dilated. Actually, it was post-dilated in the LAD as well. This is the final result of both PCIs. There was 2 stents placed in the LAD, one in the mid and the other one just proximal to that overlapping stents. and we decided to leave alone the left circumflex, which was heavily diseased. This is the final result. One more image to go, and we'll briefly talk about blunt cardiac injury. You see that the patient still has that blunting of the distal LAD here. So the hospital course, on hospital day 5, she developed a non-occlusive DVT in the right common femoral artery because she was in complete bed rest before the hip was fixed. An IVC filter was placed. On hospital day 9, she underwent a right intramedullary nail placement of the right intertrochanteric hip fracture, and 3 days later she underwent a left tibial plate placement, and on hospital day 18 she was discharged home actually. So the clinical features of blunt cardiac injury can vary widely. Given anatomical location, LAD is likely to be affected, and the manifestations could be dissection, hematoma, thrombosis, or laceration post-blunt chest trauma. Major structural injuries such as chamber rupture or perforation often result in death in the field, and we don't see those patients in the hospital. Nonetheless, concerns about major bleeding complications often delay coronary interventions inappropriately. The types of injury in blunt cardiac injury could be myocardial rupture, could be septal and valvular injury, acute coronary syndrome, cardiac dysfunction, and arrhythmia. Our patient had the ACS manifestation. Management of MI in the setting of blunt cardiac injury is controversial, as you can imagine, due to rarity of the disease and presence of multiple injuries. Thrombolytics are best avoided unless CABG or PCI are unavailable due to risk for severe bleeding complications. The first case report from traumatic coronary thrombosis with myocardial infarction that I could find was from 1949, and it was published in the Archive of Internal Medicine, and it was just a post-mortem study, and as you see that, it's showing a large subintimal hemorrhage in the mid-LAD. The other case report was in 1954, and it was again a trauma that has caused a coronary artery thrombosis, and it was published in 1954 in JAMA. There was another case report in 1989, and a couple of them in 2005 and 2014, and all of them had happened in the setting of blunt trauma. Our patient did fairly well due to the very markedly increased troponin I. We decided to take the patient to the cath lab. However, as I mentioned earlier, there is controversy when to take the patient to the lab, what to do, because when we do the antiplatelet and we do anticoagulation for these patients, we increase the risk of bleeding tremendously. However, our patient really did well, and the troponin kept downtrending even after the PCI. Thank you everybody for your attention.